I have to say, I think set against the backdrop of the extraordinary revolution in immunotherapies, for me personally, I don't think I've worked with such an extraordinarily effective and promising oral agent before as Mezi, and in that same context, IBA. Your thoughts, Thanos?
Yeah, I think it is remarkable that you have an oral agent that has single agent activity, as you published a few years ago in IMiD refractory patients, yes. Durable responses, predictable toxicity, manageable side effects that could be combined with many of our novel therapies, because these novel therapies usually they are not associated with a lot of neutropenia. So there is a way to combine and not to have overlapping toxicities.
Right. Katja, your thoughts?
I think when we talk about myeloma treatment today, and you mentioned the IMWG summit, we really can state that this disease turns now towards a curable disease, and this needs also that we develop regimens which have a fixed duration treatment time. And so those powerful assets and drugs give us potentially, when we combine it correctly, when we do find the correct sequence, give us the possibility also to do fixed duration and to enable patients long-term remissions towards cure.
No, I think it's very beautifully said, Katja, because to sort of drill down a little bit more, so that the sort of fixed duration would apply to the platforms that are exquisitely powerful but can potentially carry risk the longer you carry on, for example, some of the bispecifics. And in that context, CELMoDs open that whole door, don't they? Especially with a maintenance strategy that could really work. So I think you're absolutely spot on there, Katja. And Rahul, just to sort of wrap things up from your perspective, as you think about CELMoDs, and you've obviously got extensive experience with other oral agents, what sort of comes to mind?
Yeah, absolutely. So I think just that thinking of them dually as anti-myeloma and pro-T cell drugs, I think is such a profound shift in the field. Many of us talk about using pomalidomide in the setting. TAL3, again, included a TAL-Dara-Pom arm with that idea, that hint of synergy pro-T cell actions. It's not a hint here. It's a clear signal for making T cells less dysfunctional, more active. And, bispecifics and CAR T therapies are amazing drugs, but they need friends. I think, unfortunately, bispecific antibodies, there are a lot of single point vulnerabilities whether it be target mutation, antigen loss, or T cell exhaustion, T cell dysfunction. And I think if you have to choose a friend for those immune therapies, either in conjunction or as post-CAR T maintenance, the CELMoDs are the natural choice.
No, well said, and I think so. I use the term dance partners because they can be really critical as we think of it. But the other term I like to use is we need all hands to the pumps, because unfortunately myeloma remains. I think we're right to be aspiring for cure, but I think we all recognize for those patients we see in clinic who have heavily relapsed refractory disease, we've still got a lot of work to do. But nonetheless, a very exciting ASCO, a very exciting EHA, lots of promise for our patients, wonderful opportunities for community access and clinician awareness in this setting. So I'm going to wrap up today's session by thanking very much our extraordinarily esteemed and wonderful panelists, Katja in particular first, because I know you've made special arrangements so you could be with us today. Thanos, good luck on Sunday.
Thank you.
Equally, Rahul, good luck with your presentation.
Thank you.
And again, thank you to you, our audience, and to SOO and CIDA for allowing us this opportunity to share our insights and thoughts on this very exciting bodies of data.